Hello, and welcome to Psychedelic Chat. This is Wendy Marusic. I'm one of the co-founders of Open Nurses. Today, I have the distinct pleasure of interviewing Sam Schulze. Sam is a psychiatric mental health nurse practitioner and co-founder of Daydream MD, Integrative Health and Wellness in San Diego, California. At Daydream MD, his work has largely focused on enhancing nurse education, training within the ketamine therapy field. He develops protocols that enable nurses to fully utilize their innate skills in supporting clients throughout their ketamine journey. Currently, Sam is co-authoring a ketamine therapy nurse training course for the American Society of Ketamine Providers. A key passion for Sam is increasing access to ketamine therapy, both economically and geographically. Collaborating with the interdisciplinary team at Daydream MD, he helped create a group ketamine treatment model that significantly lowers the cost of in-office therapy. Additionally, Sam works part-time as a prescribing provider for Innerwell Health, an online service offering at-home ketamine treatment. It's my great pleasure to introduce Sam. Hey, Sam, how's it going?
It's good. Hi, Wendy. It's great to see
Hi,
you.
good to see you. Thanks so much for agreeing to be interviewed. Yeah.
Oh gosh, it's a real pleasure. I mean, I've known about open nurses. I think the first week I learned about ketamine therapy
All right.
and had reached out, and so that's kind of a full circle moment for me here in my psychedelic nursing career. So it's a real
Excellent.
honor. It's a real pleasure.
Cool. So yeah, Sam and I first met again, I guess, at the we were medical providers for the Naropa grad student psychedelic program, providing ketamine to 120 grad students. I think that received ketamine. And, yeah. So, all right. So, if anyone's joining us live, please enter into the chat where you're joining from. So, why don't we start with tell us about the trajectory of your nursing career? Like, how did you become a nurse? What you've been doing, and then how did you get involved with psychedelics?
Oh man. Well, I got my nursing degree in undergrad, so I was around the beginning of my senior year of high school as I started to look at colleges that I kind of pivoted. Really can't really exactly pinpoint what it was. I was, really thinking, heavily about engineering for most of middle school, high school, and I had a couple of aunts that were career nurses in different fields. One in like a neurology clinic. One who did critical care and then did her nurse practitioner degree and did some like primary care nurse practitioner work. And I think I was, you know, right at that like Christmas time, my senior year of high school, kind of deciding between how I was going to. And to me, it was filling out bubbles. It was like how am I going to fill out these? Do I want to pre nursing, and mention that I was thinking about nursing, and to watch my like these women, their eyes light up like, oh my
Uh,
gosh, this is such a their career arcs being so different. I think that was a really big thing for me. It's just like I don't really know. I don't exactly know where I want to live,
mm-hmm.
what I might want to do for work. So keeping things really broad was a real attracting factor to me. And at that point, I mean, I was thinking broad, like, oh, maybe I'll work in different floors of the hospital. I had no idea how broad the field really was at that point. And then learning, through I knew about the travel nursing programs. Like, well, maybe I'll go check out a couple of states. Maybe I'll move to Southern California and learn how to surf. Like that was where my head was at there. Like, it
Right.
seems
Yeah.
like a cool thing. And then, through nursing school, I kind of stereotypical, but I thought the like high paced action and the exciting, like, working in trauma, working in critical care, working in the emergency department, that was really attractive to me. So that's what I did out of college. I went straight to working as a nurse in the emergency department, and that was
Nice.
kind of my first. real true experience with the healthcare field was in a metropolitan ER in Michigan. So
Oh,
couple specialty changes and several moves later, and I was there back after after a few jobs. I worked in critical care for kind of on and off for about 2.5 years, bedside total for a little over 8 years. And I was working in the emergency department. This is 2022, post COVID, had done some moving around, had seen all the high paced blood and guts and gore that I really ever wanted to. And I was really looking like, where am I going to go from here? I thought the, office type environment seemed attractive. The more consistent hours seemed attractive. I was looking at orthopedic surgery, doing something kind of specialized in, getting into like an orthopedic surgery field. I was looking at going back to physician assistant school to get some training in acute care and in like a surgical specialty, and that's where I kind of was. I even retook some undergraduate classes to gear up to really shift gears, and then I met
an NP. Yeah, interesting.
yeah. I think I at that point was I had worked with so many more PAs working in the ER and in the ICU. I didn't see a lot of nurse practitioners. In my head at that point, again, it was just didn't do my research, but I was thinking, the NP was really geared towards like primary care. I had never considered a career in mental health. And it found me, this like, I think this, psychedelic origin story that so many have, where it in part wasn't necessarily something, or I was seeking it without knowing. And, I was looking at like all the things I really liked about nursing, was really attracted to about the job. And that was in part how I found Open Nurses.
Okay.
But so I was working in the ER, and one of my ER doc friends, and his name is Arslan. We had a few shifts together and developed a friendship. And I really admired the way that he had retained his compassion, even though, throughout COVID, and, he worked emergency medicine in New York City. I did for a while as well. I was, it's hard work. It's very, very intense, and he had, retained that. So I was interested in, his offer to work in a ketamine therapy clinic. He had the idea, had taken out, the office space, but hadn't treated any clients yet, needed some nursing staff. So we kind of buddied up, and it was this like experience of kind of being awash in this realization that like, and that, to put it, I'm kind of quoting Andrew Penn here, but a return to why I felt like I became a nurse in the first place. This like the genuine connection, the time with people. Those were the enjoyable experiences that I had working in acute care. And unfortunately, they were very few and far between. And I did feel like I was kind of sold a bill of goods as far as like the making a genuine connection, learning to support people's whole their whole person. It's kind of like whole human, biopsychosocial, spiritual wellness that, our nursing forebears designed or hoping to design. And it was sitting in those rooms, those first several weeks, months of, greeting in people into our office space, in this, what was the original form of Daydream MD then. It's taken a very different form now after 3.5 years, but greeting people into our space, really having the time to learn about them and connect, and then, kind of perform this procedure and hold the space for them and see them through a series of treatments that, that was the connection that was really hoping for, hoping to develop while I was working in, acute care. And those were the interesting, those were the experiences when I did get to take the time to get to know somebody and hear more about what got them there and where they were hoping to go after that did fill my cup up. And I saw that, I like it was a big watershed moment of like, oh, this is really like, I don't know if I would have found it if it hadn't found me. And this is what I've been kind of looking for. So I actually fired off an email after watching an interview of Andrew talking about just that. I think that was, almost verbatim. His quote was like, "This is a return to why so many of us become caretakers, become nurses in the first place. This opportunity, with the time that we're able to spend." And I fired off, a cold email, asked, "Do you have any advice? Do you like your job?" And the response that I got was, not only quick, but so enthusiastic. I applied to graduate school and worked on building this clinic and have really seen, it's been really gratifying to see it change. And my role, of course, changed from the only nurse in the clinic to, our nursing director, creating our training programs, creating our internal policies and procedures, to now designing the treatment plans and doing all the initial evaluations and follow-ups, and continuing on kind of in this prescriber role that I still get to get in there and facilitate some treatments, both individual and group, every now and again, which I really like doing it all. So there. I think that answers your question. That's my, my how I got here story.
Yeah, so you went back to school and got your Psych MP then.
I did, yeah. Yep.
Right. You went during COVID to school?
No, actually,
got it before.
it was after. I started the program fall of 2022 and I finished.
Okay.
I finished just over a year ago, May of 2024. So I've been working as a nurse practitioner since August of last year.
Okay, yeah, so about a year.
Mm-hmm.
Yeah.
Mm-hmm.
And that was great. You already had a job to go to, right? You already had this clinic. Co-founder of this clinic, right?
Yeah.
And so, so tell us a little bit more about your clinic. What does your clinic do?
Oh, yeah. So we are I feel like, I think that like tagline, integrative health and wellness, it's funny. I see a lot of organizations with their, have their name and then their kind of like subtitle. And, what I really do feel strongly and passionately that we are that, integrative health and wellness center. So we do ketamine infusion therapy. We have an office. We do like individual IV infusions. We, as you mentioned in my introduction, we do a open enrollment group ketamine treatment model that is something that we either pioneered to increase access to the medicine, the like parenteral form of the medicine. So we do that. We run groups of between 5 to 8 clients through twice a week, and we do intramuscular injection of ketamine in that format. And we also have a cadre of therapists who do both ketamine assisted therapy, ketamine integration therapy, and different. Not everyone who comes to our clinic does ketamine. We have done a lot of administrative legwork to be able to take insurance for the major providers of insurance in the area. We're in San Diego, for therapy services, for psychiatry services. So, again, I am designing ketamine treatment plans for our clients that engage in ketamine, but not all of the clients that I see. They're able to find me through their insurance for what I call traditional medication management. And we also do so since I've taken over the oversight of the psychiatry department and the treatment planning department, our medical director, who is emergency medicine trained and functional medicine trained, is doing some functional medicine, kind of like physical medicine, health and wellness oversight of that program. So, really, we wanted to design this wraparound care model where somebody wouldn't necessarily have to come to us and say, I want this, I need this, or this. They could just say, I need help. And
you'll figure it out.
How can you help me? Yeah. And that's been, again, being able to, it's a challenge. I was looking at it before I got into mental health. You'd think I would have thought it'd be much simpler to, see somebody for medication management and then have them say, oh, based on this, I think you'd benefit from this type of therapy. And here's a referral for therapists who do this type of therapy. And it would be more seamless, all under one roof. And I've been surprised at how siloed the different care models, different care, treatments are in mental health. And I do think that that's an unfortunate barrier that many people get stuck on.
Absolutely.
To try to reduce that barrier as much as possible. I know the last chat that I saw you, and you were talking about Spravato treatment. And that's another thing we started relatively recently. I think about 2 months ago, we started the Spravato program to continue to allow for access of a form of ketamine through insurance.
Through insurance, that's why we use it at our clinic.
Mm-hmm.
Yeah, at Mental Health Solutions, because it is covered by insurance. We're limited on the dose. We're limited on the intranasal, either 56 or 84 milligrams. It's S-ketamine instead of racemic. It can work really well for some patients, and it's the tool we have right now, at least at our clinic. Yeah. So being a nurse, right? So you worked in emergency and critical care and some other things, right? Now you're on the psychiatry side. So do you think nurses, we bring a different perspective to psychedelic therapy, ketamine therapy work? What do nurses bring, right? So you're working, there's a doctor in the clinic, maybe you've been at other clinics, is there something unique nurses bring, or
Oh man. I think I could, and I will answer that in many different directions. First, I think when I first started working in psychedelic spaces, one of the first handful of experiences that I had was facilitating ketamine assisted therapy for a group of clients who were coming for a ceremony that was designed by a couple of therapists in our network that, they'd attached to us, and said, we need some medical staff for this. So I, went and facilitated that. And one of them came up to me, and I'd heard this term holding space a lot, at least a handful of times in some of the independent research that I had done into psychedelics, and then heard people say it. And I did have the confidence when she said, she's like, you seem pretty natural at holding space. It's nice to facilitate with you. And I asked her, I'm not exactly sure what that means. At this point, I'm afraid to ask. But she, because I'd heard the term a couple of times, and she explained it. And I thought back, and it was my first critical care job. I worked in oncology critical care, and it was very heavy emotionally for so many of the people around. Of course, the patients, their families, the different, everybody working. I mean, it truly was.
Yeah.
There was a lot of space to hold, and having that experience without necessarily knowing what to call it, of, when to, doing what you need to do, when to take up as little space as possible in the room, when somebody's looking for you to maybe take up a little bit more space because they're scared. when they are utilizing wanting to get to know you as a way to distract them from distract them, or wanting to get to know you because they're interested, because you might spend 36 hours with somebody in 3 days. If you have the same family 3 days in a row, you're like, that is that's a lot of space to hold. And I think when I'm designing these like education training, nurse facilitation modules, I like don't have to necessarily, I think we've all in our different ways all have this background of doing exactly that, kind of like reading the room and forming into what is the optimal engagement form in that particular scenario. And I think that's a massive benefit, just the background of nurses being in those spaces with people who are not always necessarily in, they're not always necessarily sick. There were some triumphs in that intensive care job. There are definitely triumphs that we witness as nurses. So, and that's another thing that you want to have some skill in holding space with. I also think we have this really unique ability, just licensure wise, to administer medications. Like, some of this does come down to the way that the pieces fit together, in terms of who's licensed to hand a medication to somebody, who's licensed to give an injection, to start an IV, to give IV medications. Like, there's a structural component to what makes nurses ubiquitous in this field. And and a final one, and one I think that I think is, I don't want to say the most important, but is a very important thing that the entire field of psychedelic psychiatry, I think, has yet to really grasp, is the economic premium of nursing staff.
Mm-hmm.
We can make these medicines so much more accessible to people in a way that both covers their physiologic safety and their psychological safety. And that is, I do think it's a problem we're already seeing, and it's a problem we're going to continue butting up against in this field as more medicines are available, is that pure out-of-pocket cost. I want to see more tools. I want to see, ketamine. I want to see plant medicines really move into, in my career span, move into a utilizability, premium, where they are making a dent in the mental health crisis in our country. And I think I don't see a way that happens without nurses being integral in their delivery.
Yeah,
for all of them.
Mm-hmm. I agree. That space holding ability is such a huge thing that nurses bring. That's not something you can just teach. So you have to figure that out kind of on the fly, right? You're assigned to this patient. So, I worked night shift for years in bone marrow transplant, which is highly acute, right? Oncology situations, where you form long relationships with these patients. But you're assigned to this patient, whoever they are. You got the next 12 hours. You two are together. Right? The family members, the patient, whatever they're going through. And you're going to stay with them through, thick and thin, through cranky and happy and everything in between. And right.
Yeah.
So I think the creativity and the kind of the ability to sort of shapeshift and translate and form a connection with the patients. You may not have much in common other than you're both assigned to that room that night, right? One is a patient, one is a nurse.
Yep.
But you figure out ways to connect and to relate and to make each other feel safe. And I think that's huge for in psychedelic spaces.
Yeah. And one thing that I'm really grateful for the like trajectory of my kind of evolution through this was that I did spend those first 18 months or more, and in the room. That was my role. Was our medical director would do the initial intakes and talk about treatment plan, and then I was the one who he would, for every hour that he might spend with a client and getting to know them and doing the necessary interview piece, I would spend 8 to 12 hours with them and their families who are dropping them off. And I think now that I'm in that other role, I think I just have a really intimate knowledge and experience that, like, though I might be one of the people they're talking maybe a little bit more detailed of the treatment plan, like, our nursing staff is the nursing staff. They're the face of our organization. They're the people see. They're the ones that they develop relationships with. They're the ones that they celebrate celebrate the triumphs with, and lament what needs to be lamented. They're the ones who are sitting with them through these powerful experiences. And I'm really grateful to have, to really hold that, because I do think sometimes where I do think, as I'm not spending as much time and seeing more people, that I do forget that at times, where it's our nursing staff that's guiding these folks, through these steps, and they're the ones who really have the, really juicy downloads from their experiences that, again, I'm grateful to be all in the same space together, so I can hear some of that from, some of those experiences through the eyes of our nursing staff.
Right. Yeah, I do miss that some, now being a nurse practitioner as well, and seeing patients for 30 minutes or only at a time. Kind of miss that, being able to keep just checking in or drop back and forth into the room or not, or yeah, it's also a big shift switching from inpatient, to outpatient.
Yeah.
Like, okay, see you in 2 weeks. I hope they don't come back, or they don't. There's no one to keep checking on them. Yeah. So on this line, I think, do you feel that nurses need an advanced degree to work in this area, or not?
No, but I don't think. I think some specialized education is necessary, not necessarily a degree. I think, though, there's so many aspects of these inherent nursing skills, like holding space, like dialing in physical comfort is huge in the ketamine space. A pillow can be the difference between a comfortable and uncomfortable experience or infusion. And there's things they're sixth senses, reflexes for so many nurses. It's beautiful to see. And there is, I do think that another level of therapy specific training to fine tune some of our instincts is necessary in this space. And I'll detail out a really beautiful way that this is played out in our organization through our interdisciplinary care team. As we started to bring in more therapists for facilitation, for our group administration model, I had two of our therapists come to me on the same day, one in the morning, one in the evening, who they were very new to our organization. Within just a couple of weeks, we were really starting this therapy program, and met them and been in their like, their interviews, but not necessarily like a direct report. And we were just getting um, comfortable and familiar with one another. And they both came to me, and I could tell, but I got an energy of both, like, hey, I don't want to overstep. I know I'm new here, kind of energy from both of them. And they mentioned that they're like, they, mentioned, two separate occasions where, during one individual, one group ketamine journey where somebody was showing some signs of distress. They were breathing heavy, or they were starting to fidget. And a member of our like, nursing staff went to check on them, to, give them some, some of that like comforting energy, as we're so wont to do, as that is an instinct
Right.
in nursing, right? Is to ameliorate suffering in any way that we can.
Mm-hmm.
And the therapists both had like, I see what it's a nice thing to do, but I really wish they would have let that person self-regulate. Part of what we're doing here with this not is helping those under our care develop their own self-efficacy to self-regulate in these spaces. And though, yes, intervening at overt signs of distress if somebody's requesting, but
Right.
allowing somebody who is showing that kind of mild to moderate level of discomfort, even because you don't know necessarily if it is discomfort, but
Right.
to not necessarily jump on that reflex or that instinct to soothe immediately. And that was this like, honestly, that was a huge moment. I brought that information to Arsalan and Lisa, the other kind of co-owners of Daydream, and I'm like, oh, if we're going to do this right, we're reliant on our nursing staff to facilitate. And to answer Contra Clover's question there, curious about how RNs are going to be um, involved, in the role in the future. I do think that this is part of it, where with some, with some dedicated and detailed teaching of like, all right, here's some instincts to absolutely act on, and then here's some instincts to recognize and know when to not act on them. Because having somebody who's having a psychedelic experience, both with a nurse to monitor their physical health and a therapist to do the facilitation, the the cost of that really adds up very fast. And I do think that with guidance, that a nurse, again, with that licensure to take and monitor vital signs and administer medications, and the training to not necessarily it doesn't need to be dedicated psychotherapy, but some training to maximize somebody's ability to hold their own space and to self-regulate, and then to see their therapist for the processing, the unpacking, the tool building, that stuff that they're specially trained to do, does maximize resources, this like kind of like staffing resources that might come back to the client as an overhead, come back to the client as a cost. We're
Right.
trying to maximize that as much as possible, and that is the way in which that I think both group medicine and specialization in nursing
Mm-hmm.
in that way are going to again, like, progress this field further than it would uh, without nurses being adequately trained and represented.
Right. Andrew and I both talked about how, you know, the skills you learn as a nurse covers the majority of what you need to be a psychedelic sitter, right? We
Mm-hmm.
know
Mm-hmm.
hold space for people, right? We know how to monitor their bodies for signs of distress, right? We can administer meds, we can do vitals, all that sort of stuff. And then if you
Mm-hmm.
add on a little bit of psychedelic education on top of that, they have most of what you need versus taking somebody who's really highly trained in therapy, but they have no idea about, right, physiology or medications or body mechanics, right? Walking someone to the bathroom or helping somebody who's nauseous or those sorts of things. There's actually a lot more to add on top of like to a therapist or a psychiatrist who maybe hasn't touched a patient, has actively not touched a patient for the past
Yeah.
right? Like that's
Yeah.
like, you learn to not touch people. Like that is a skill people have to learn. Right?
Right.
Go into right.
Yeah.
Yeah. So
Mhm.
so you're working on designing some education for
Mhm.
within your clinic or is it beyond your clinic?
Yeah, it's actually it is uh, beyond Daydream. I attended the ASKP3, the American Society of Ketamine. I think it's practitioners, providers, and prescribers. There's three Ps.
Okay.
They had a conference in Austin in January where I linked up with some friends that I met actually where I met you at the training in Naropa,
Mhm.
and we had talked about it was one of the goals of ASKP3 as an organization. I think a lot of people are independently realizing that so you mentioned at that Naropa training there was about 100, I think it was 125 students. I, I I think less than 15 of them were nurses by licensure.
Okay.
I think it was around that 12 to 15. It was a smaller representation, about 10%, primarily therapists and some physicians. Um, so, like I said, kind of independently realizing that nurses do make up a valuable or an incredibly valuable piece on this,
Mhm.
uh, you know, on this chessboard. And there are tons of trainings geared towards therapists and a lot of trainings geared towards physicians, both how to facilitate and then how to run these clinics. And there are a lot of resources out there, and a real dearth, a huge opening and need for some dedicated ketamine nurse training. So I found the ASKP representative and said, "Hey, I see you want to, start a nurse training. Where are you at with that? And can I get involved?" And she looked at me wide eyed and she's like, "Oh my God, please."
Oh,
So, so that's I got teamed up with another nurse practitioner to co-author that course.
Mhm. That's great. Yeah, we were realizing when we just so we're just at Psychedelic Science in
Mm,
just last week, right? That was a big psychedelic conference. And Open Nurses, we had a meetup. We had over 100 nurses, all nurses, nurse practitioners in our room. And when Andrew and I were introducing kind of what Open Nurses has done and does in the past, and we serve to represent nurses, and we speak up when nurses are left out of something or make sure they're included, kind of thing.
mm, mm,
And we realized as we were explaining this, we were saying, and every time we've spoken up, there has been no pushback. People are like, oh yes, thank you, right? So you reached out to the American Society of Ketamine Providers, and you're like, hey, we need to train nurses, and they're like, yes, please,
yeah,
speak up. Oh, we need, a nurse. They're like, oh wow, yeah, yes.
yeah, yeah. I
Um,
think it was on their like goals for the year, but they didn't have that had just the beginnings of, again, honestly, like who might best serve to, uh, to design that course. And, and that was, when I kind of tossed my hat in the ring, it was, very well accepted. They're like, oh, we're really grateful. So, I think you bring up a really great point where there is like, I think about this a lot in just psychedelics in general, but I think some of I'm not sure how realistic much of the division that seems to be there really is. And I do think that especially those that are running clinics involved with, the clinical side, this like brick and mortar kind of clinic side of medicine, are very aware that nurses are providing a lot of the clinical structure and safety in their spaces.
yeah. So let's see. So what kind of role do you see nurses taking in terms of like changing laws or policies or harm reduction, beyond a clinical setting? How do you see nurses change in this field?
I think I just keep learning and learning and learning what, broad array of things that people are doing with their nursing degrees. And I'm learning more and more about nurse coaching
Mm-hmm.
from, some people kind of in my like orbit here in San Diego that I respect immensely for, their work to, empower nurses to think outside of what is a typical nursing career, to use their skills to help people. And I do think that though I wouldn't, I've never been a nurse coach. I don't know what those certification programs are like. I really, I really don't know much about that field. However, I was discussing one on actually, a similar type, interview with somebody who does some of that work. And I think my overall, point was that I think this is coming out and we're seeing it more and more in different ways, but the product, this like the actual product that is insurance covered healthcare or illness care in this country, it leaves so much to be desired that many people are. And now that, I mean, there's more information readily available, health information more readily available through, um, you know, through sources like this, through interviews, through, some of these. I think of like Andrew Huberman, or these other resources that people are really desiring this. Not I said that intentionally. Our healthcare system, I refer to it as our illness care system, because
Mm-hmm.
its real function is to get you better when you're sick. But we're seeing more people. I think there's a massive intersection of people who are interested in psychedelics and people, this Venn diagram between, people who want to utilize psychedelics for their health and well-being, and people who are more interested in a wellness care model. And I just wonder if there's a massive space in that, market for people utilizing their nursing degrees to facilitate, folks learning. I think of, there's a nurse in our organization who does like nervous system regulation workshops and courses, and it could be the first time that somebody's hearing that they can manipulate and modify their autonomic nervous system, their anxiety, this catecholamine dump that they get from stress with breath work, with tapping, with things like sound healing. There's so much there that doesn't necessitate a degree to prescribe, or a degree to do, again, like, internal family systems therapy or EMDR, or these like kind of, granular therapies. Just simple connection. It's not that, I don't want to downplay by calling it simple, but like
Mm-hmm.
connection and education is, I mean, that's another, like, nursing reflex, right? That's our role, is, there's the connection and the educating after, somebody delivers a treatment plan of what that necessarily means. We're very equipped to do that. And I think we're seeing, again, with the rise of concierge medicine, with the rise of functional medicine, with the rise of psychedelic medicine, that, our consumer base, right, the public, they're not accepting this, oh, I'll come to you once I'm sick model of care anymore. And though I don't know exactly what it'll look like, um, and may not even, that isn't psychedelic specific necessarily, I do think that that's a wonderful role for nurses to explore and to step into, to fill that need.
Mm-hmm. Yeah, the nurse coaching is interesting. We've had several people I think we've interviewed who are nurse coaches. One of our co-founders, Angela Ward, was kind of on the edge of that wave that's going through nursing.
Actually,
Yeah.
So we were talking about the psychedelic science conference, and one of the ways in which I'm kind of just curious your thoughts, or maybe we can discuss, because I saw a lot of talks, and it seemed like seemingly a lot of interest in microdosing. Presentation of studies, presentation of literature, and it's really piqued my interest, and not in the way that you might expect. We're seeing these, like, when you talk about like ketamine therapy, psilocybin therapy, MDMA therapy, like, the remission rates for, PTSD are, massive. And there's this, like, talk about, a medicine like Ibogaine, where there's, just this quantitative data of reduction in suicidality, all of these markers, and there's this, like, really seeing this, like, massive step off and change. And yet, the data that I saw presented on microdosing, there's so much enthusiasm. It does seem to me to be a lot of enthusiasm for microdosing. Both, it seems to be very much in the zeitgeist, different microdosing products, like all this, and yet the data where at least in the handful, I think I attended three lectures on microdosing. The data, they're like people in the control group and people in the experimental group, they all improved.
Right.
But they didn't improve any more from microdosing psychedelics, at least in like a quantitative.
Okay.
And those are the things that I think.
It's hard to study. Yeah, but
Very, yeah. But that, what piques my interest there is both like, again, it's in vogue, it's going along in like the zeitgeist. It's what would be like a low, potential if these medicines were were legal or legalized, like, there wouldn't be as much of an overhead cost, more people could potentially access them. Where I think this ties into like the nurse coaching thing like I was talking about, but I'm kind of curious what seems to be it's the programming. It's like you microdose and get into an exercise routine, or use it as using it as a catalyst to kind of like to really like drive some change, using it as like,
right.
to me, it feels like many, and I'm curious your thoughts here, many people look at like microdosing as this like gift to themselves for their self-improvement and self-betterment, and going along a program. And yet somebody who sees a psychiatric provider and gets prescribed Prozac or Lexapro would see that as like could potentially see that as like a failure of their own will, see this again as like illness, where I wonder what I wonder about the difference in like, energies of those two things. And again, this is very much editorialized from just what I'm seeing in my experience, but I would love to see people bring that same energy to like, I've tried all I can. I'm still struggling. I want what's better for myself. I'm going to take this medicine and I'm going to utilize it to make this change, rather than again looking at it like, oh, here's this thing I like have to do because I can't manage on my own. I don't know. Is that?
Yeah, I mean, when I prescribe psych meds in that same way, right? That yeah, these are a tool, right? Prozac's a tool. We take it at the level amount you need to help you through this, time. It will enable you to make the changes you need to make in your life, right? We can't just medicate your life away, but right, we can remove some of that, the anxiety, the rumination, the passive suicidality, the thoughts, intrusive thoughts, right? And then you make your life changes, and then we can peel those meds off, right? So I think kind of roll out similarly to microdosing, but yeah, I mean, microdosing, I think, has a great potential for nurse coaches or nurses to work with, because when you're not having some of these huge experiences where maybe, there's higher risk there. There's risk for, psychosis or, some serious, right, trauma
Right.
and other things that maybe you want a therapist or,
Mhm.
a psych NP or a
Mhm.
psychiatrist to be there to, to help hold that.
Yeah.
But then, I mean, that sort of is the joyous model, is using not quite microdose, but mini doses of ketamine, daily or almost daily, but to enable them to do different practices, right? So to
Right.
do, then engage in meditation or yoga or journaling, or,
Mhm. Mhm.
it alters you just enough that you could step outside of your old routines and form new ones, right?
Yeah. 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 I have been, you mentioned that I, was working as a prescribing provider for Innerwell, and that's a relatively recent. I think I've been working for them for, 3 or 4 months now. And I will say, I kind of, I took that job because at that Naropa training that we attended, I saw their medical director, I think, say something that, really connected with me, because I'd realized, in this, like, in the brick and mortar, clinic model is not only limited financially but also geographically.
Mm-hmm.
And it really piqued my curiosity, because I would like to see this medicine widely. But like I said, I want to see it not just make a dent in, kind of the elites of the coastal elite cities,
Mm-hmm.
but in this overall health and well-being of our, of our entire country. And, I think an online model, I wanted to see, like, hey, what does this really look like? Do I feel like it's safe? Do I feel like it's responsible? Do I feel like, we're doing more harm than good here? And I will say, very, very impressed with.
So you're prescribing at home a sublingual ketamine.
Yep.
People. So these are people you've never met in person, or you just meet them on video,
Right.
and
Yep.
prescribing. And then how are they using it? Yeah. Or what do you?
Well, yeah. So you mentioned the joyous model of, like, more frequent, smaller doses that are not necessarily, we'll say, sub psychedelic, or sub, maybe not sub perceptual, but sub altering. The Innerwell model is more like the, um, more designed along the lines of the ketamine as an antidepressant model that has been studied. This, like, 2 sessions a week for a number of weeks, and then, tapering from there for the most part. They do give some. Another, I've been very impressed. They were fully like, you have experience with this. You can design your treatment programs as you'd like to. So I do have a lot of flexibility. I'm not kind of copy and pasting, rubber stamping, like, okay, do Innerwell model A or Innerwell model B for people. I have some flexibility to create a treatment plan that's best going to fit somebody and their needs at that time. But again, these are, we'll call it, say, like, dissociative doses of ketamine,
Okay.
starting with more frequently and tapering off to less frequently, kind of like these original. We're kind of like the industry standard in the infusion care model now. And I had thought of, oral ketamine more as a tool for maintenance treatment, or a tool for ketamine assisted psychotherapy, but really do see a lot of positive impact for, I think, people who are at more like the, I think, mild to moderate, scale. Somebody who's got, um, active suicidality on board. There's a little bit there. It's definitely more conservative than I would maybe be through Daydream, but, I've been,
Right, but they're
largely impressed. Yeah.
all alone, right, when they're using this, or is there any
They
parameters on that?
they they necessitates them having a sitter in the home,
Okay.
so they're not monitored. There's no, like, medical professional necessarily with them. They can opt into a facilitated session where they're on, video with a therapist to do some, um, like I said, kind of like facilitation. But they aren't sanctioned to be alone in the home either. They have to have a sitter. They take their blood pressure beforehand. They record it. They record their dosing, they record some notes about it, and they collect a lot of data, a lot of state questionnaire data.
Okay.
What
helps with the accessibility, right? So then
it's getting, where, and you mentioned it a little bit earlier, but my new, I won't say obsession, I won't be that dramatic, but my new real interest is like ketamine assisted or ketamine facilitated mindfulness, where somebody might take and this would be more in when somebody has like a relationship with a familiarity and relationship with ketamine. I often find people, at least those that I see for like continuing care, not just reduce. I'm really encouraging not just reducing the frequency that they use the medicine, but also the dosage. I like started to really pare down the like overall, each session dosage to one where somebody can remain a little bit more active
right.
in their experience, to do something like a guided meditation or we'll say like a mild intensity breath work, or do a breath work like practice, or a sound healing practice, or something that involves some type of structure and programming to build these mindfulness tools. I talk to so many who, have you tried meditating? I feel like almost everybody I've talked to is like, yeah, I've tried. So many I've tried, and I'm not, it's not really sticking. I'm not sticking with it. And I think the way that, ketamine facilitates, kind of like lowers that threshold to really feel that oneness, mindfulness, allows people to, access that, and access that outside of the medicine, which really benefits them in their that like dominion over automatic thought. I think that's my new, like, real, like, kind of passion area and real interest area, is like, how can ketamine be used again, like, creatively. You also said it earlier, this like, what's the minimum dose at the minimum frequency to produce the desired result? And that's a way that I think getting people to focus more on the tools that they can build with the medicine, rather than putting the emphasis on the medicine, both protects from overuse patterns. Again, editorializing just from personal experience. I haven't run the studies, but I like to think that it is a reasonable way to think, protect from overuse patterns, protect from putting too much efficacy into the medicine and not enough on their own ability to heal and move some of these,
Right.
anxious energies, low mood, things like that.
Yeah. So, all right, we're getting close to time here. If anyone tuning in live has any questions they want to put in the chat, that would be great. We have one here. Let's see. This is from Khaki. So, other than ketamine, in which ways do you see functional medicine and mental health intersecting?
Yeah. Gosh, many. I think, particularly my experience with our clinic, I'm very, very interested in both hormones, testosterone, whether it's, testosterone supplementation, or just like monitoring estrogen, progesterone supplementation, or monitoring in those, like, again, like, kind of, that's more of a functional health with, more detailed testing, like blood work testing, than you might be able to access through a primary care provider. I'm very, very interested in the intersection of mental health and GLP-1 medications. I have, so, in many ways, right? And I do encourage anybody listening, if you're interested, to look up the mechanism of action of, Ozempic, tirzepatide. I wish I could regurgitate it to you with some confidence here. I know that I've looked it up several times and have been like even at the first kind of interested, like, oh, this does seem different. It's a anti-inflammatory at these, in um, the okay, well, the like blood vessel system, specifically, in the brain, it does seem to modify craving overall.
Absolutely.
Right. And modifying, I'm big because, from a background in ketamine, I'm a real believer and proponent of transitional health models, but mental health is my, like, specialty of, like, um, what is a medication's role in a transition, right? From one way of living to another. And I do think keeping an eye on the holding to that, like, what does this help with transition, does, I again would hope, minimize polypharmacy. And one of these ways I think of, and so what are good tools for transitional mental health? SSRIs take a long time to work. There are some, I, like you said, when you're prescribing these medications, and I do the same, it's like, what does this help shoulder the burden of, so that you can get back to, a healthier habits, healthier life structure, and then be able to shoulder some of the, like, the stress, so we can, taper off of these medications, and when is it appropriate to do so. I like to, because ketamine's rapid action, I think it's a better tool, a sharper tool for a transitional mental health model. And I think of I think of GLP-1s as a potential to fit into that category really well, for things like both just weight reduction, like purely to make exercise more possible and comfortable. I think about America's knees and how much a 30, a 30, 20 pound, 10 pound, 20 pound, 30-pound reduction in overall weight can allow for acts to even access safe, more vigorous exercise, as then a way, once that's possible, to potentially reduce the need for the medication to keep weight off. I also am very interested in some of the preliminary data that we're seeing, and how people are creatively using GLP-1s for substance use disorders, alcohol use disorder, whether intentionally or unintentionally.
Yeah, that's
And
thing they found when people started using these for weight loss, right? Yeah.
yeah. So yeah, those are just two examples, and I think there's many more.
We have one other question, and then we'll up here.
Mm-hmm.
So might be from a family member. This is from
Yeah.
not a very common last name. So this is from Hannah. They're recognizing that access is currently a challenge, particularly financial access to these therapeutic modalities. How can practitioners best utilize their limited time to advocate for better access?
Yeah, educate yourself on the resources available in your region, in your space. Educate yourself on the resources available for your clients.
Mm-hmm.
I don't think it's reasonable to expect every practitioner to be everybody's, prescriber, therapist, cheerleader, dietitian. Like, I think educating yourself on those things is good, of course, to give, like, an overall big good picture. But I think for, especially, whomever this person is, said that limited time. You have limited time. It's hard to cover all of those bases. So having, like, a good list of, ideally, personally vetted resources for, here's somebody that I know, or here's an organization that I know to be reputable,
Mm-hmm.
to access some, dietitian coaching or therapy. If it can't be all under one roof, which of course we'd love for it to be,
right.
I think, again, just giving somebody a really low boundaried path towards, like, here's a phone number to call, and this is the person you might talk to, and they really will be able to help you out. I think that warm handoff is as a way to solve for that very challenging problem.
Right. Okay. So our final question we ask everybody comes on here. So if you could go back and give your younger self a bit of advice, what would it be?
Oh man.
Yeah.
I think
Mhm.
that's a very good one. I think what's really, speaking to me here is like, I would really encourage my younger self to be more confident in being able to understand, like, not get so pent up and um, concerned about really needing to understand each aspect of each thing right away. I think, I would counsel that version to just be be open to the learning, not put so much pressure to again, like, understand these like complex systems either clinically or administratively in immediately, and to understand these like learning based goals and how there's this like does take time. And I'm also giving that advice to myself right now, as I'm constantly learning. I know how anxiety provoking being a manager of sorts was at first. And I know how anxiety provoking when we started undertaking some of this stuff with insurance was at first. And if I could go back even to those cross sections and just say, like, it's too complicated to know everything right away. Just
Mhm.
have confidence and reach out to your supports, reach out to your mentorship. You'll maybe not perform at them better, but maybe be a little more comfortable while you're doing it, which is very important.
Great. Show yourself some grace, right? That you
Be a good one.
showed everyone else, right?
Yeah.
Yeah. Take some of your own advice as a practitioner too.
Exactly. Exactly.
Yeah. All right.
All
Well, it's
right.
great. Great chatting.
Yes.
Uh,
Thank you so much. Thank you so much
yeah.
for having me. I'm very grateful, and it was great to see you again.
Yeah. So this will be available on YouTube right away. Share the link around, and we have dozens of other interviews as well. So take care, everyone,
Looking
and
forward to it.
we'll see you next month. Bye.